Um, so you know who you're having a conversation with today. So my background is eclectic. And as I said, I started out in physiotherapy many years ago. And I then went into human factors and patient safety. And it's interesting, really, because to be really honest with you, I was on this program. I think, let me just bring a bit of humanity into this conversation. I think one of the biggest injustices that society does to people is to ask us at the age of 16, 17, 18, or 19 to decide what we want to do with our lives. I don't even know that I knew what I wanted to do with my career or with my life at 25, let alone at 16. So for those who trained in Nigeria, which many of us did, you get asked to choose your subjects, and by the time you're 16 or 17, you're having to decide what course you want to do. So I ended up on a physiotherapy course, which I really, really enjoyed, really good company, et cetera, and really enjoyed the program itself. And then it came time to choose my undergraduate dissertation. And whilst my colleagues were busy trying to figure out what to do in neuro or musculoskeletal or respiratory, et cetera, running after stroke patients and COPD patients and Erb's palsy, et cetera, I was busy running after them because my project, I decided I didn't want to do a mainstream physiotherapy project. So I decided to do a project in ergonomics and human factors. And I wanted to look at the ergonomics of furniture, the effect that the furniture we sat on from experience had on our health and our posture. And so I needed them as subjects. They needed patients for their own dissertations. Anyway, cut a long story short, I got introduced to ergonomics. And from that time on, I got bitten by the ergonomic bug or the human factors bug, because I started from that time on to look for an opportunity to really try to explore ergonomics a bit more. And so I did that and got on the MSc course when I relocated to UK, got on the MSc course at UCL, and did that for a full-time in ergonomics and human factors. Soon after that, the first job that emerged was in the NHS as an ergonomics advisor, looking after human factors. And I thought, of course, I'll take it. It was a dream job from a physiotherapy and human factors background, looking after people and preventing back injuries, preventing repetitive strain type injuries, looking at hardening, work hardening program, return to work programs, that sort of thing. So I did that for 2 years. Also did that in local authority, and then quickly went into risk management consultancy, selling consultancy services along the lines of ergonomics and human factors to the NHS and local authority. And then after that, doing that and rising to a high level, becoming a director in that consultancy, I then went back into the NHS, did another MSc in human factors, in healthcare governance and quality, and then came back into the NHS and took a patient safety collaborative lead role as a program director in a patient safety collaborative in Northwest London, looking across several trusts. And now that was my last full-time role, if you like. I've transitioned over the last several months into a portfolio career where I teach in Imperial College on 2 programs, but also have a portfolio career in human factors and ergonomics in healthcare, and also in innovation and in leadership and program management. So that's not such a brief introduction, but it is an introduction because it gives you a bit of a context of some of the things I'll say. A lot of the things I'll be saying will be drawing on the last full-time role I did as such in the context of patient safety and quality improvement. Now, what I'm hoping to do today, and it's a very ambitious program, is first to make the link between quality improvement and patient safety. Secondly, to demystify quality improvement. When we say quality improvement, what are we really referring to? And then I want to briefly discuss at a very high level 5 strategies of quality improvement. So it's a very high level discussion, but I hope it if you like, it lobs enough of a of a thought grenade, is what I'll call it. Loves enough of a thought grenade that explodes in the room and takes us in many different directions so we can really have a conversation. And the reason I'm talking so fast is I want to be able to get as much information out there as possible so that we can really have a conversation about QI, how that affects your world, and how it might inspire you to do more things in QI in your own practice. So those are the 4 ambitious things, targets I've set ourselves to achieve today. Now, for me, I haven't experienced upfront QI probably for the last 15 years or so, or a little more. The biggest question I want to ask myself always is, what on earth are we even talking about when we say QI? And this is a very important question. You may not agree with me, but stick with me for another few minutes and let me explain what I mean. Now, please do raise your hand. Please do raise your virtual hand if you can say yes to the question I'm going to ask you now. And the question is this: have you ever been in a room, whether that's a physical room or a virtual room, at any time in the past, whether whilst you are growing up or as a professional or in other work settings or social settings or any other setting you might care to name? Have you ever been in a situation or a context where there are several people in a conversation and everybody seems to be nodding and discussing the same subject, but when you actually started to go around the room to find out what each person's understanding of the subject was, or even what the discussion is about, that you found out that everyone was actually talking about different things, but using the same words? If that has ever applied to you, please raise your hand, virtual hand, or put it in the chat. I can see one hand's gone up. Right, okay. Right, that's the second hand going up. All right, it must be that there are only a few of us that live in the real world. I expected to see more hands, but as it is, let's take that for what it is. A few more hands are going up, but the illustration I've just used, well, 4 or 5 hands, though, that's good. So the illustration I've just used, the reason I said I did that is really to describe my concept or my understanding of QI. My experience of QI in the NHS in the UK, in England, has been often, many people use the term QI. They use the term quality improvement. But when it comes down to it and you really start to grapple with it, you have to ask yourself, when you say QI, what do you mean? And you find out that each person has a different meaning of the term they're using. And so I wrote a blog about 2 years ago, something like that, where I really grappled with that concept and said, when we say QI, what are we really referring to? So why don't I start off again by asking you, when I mention the word quality improvement or the term quality improvement, please put in the chat box, what that means to you. And as we are writing this, I believe I saw one of the icons, I believe I saw a name Francis. I'm hoping that that's Professor Francis Fatoye, who is another colleague from the days back in the University of Ibadan. If that's you, then it's good to have you on the call.
Thank you, Kenny.
All right. It is you. I still recognize that voice from way back. Right. So now, so the question is, what does QI mean to you? Just a few thoughts. Just throw those thoughts out there. And if you prefer to give voice to your thought, then by all means, go ahead and do that. What does QI mean to you? I can't see any thoughts in the chat just yet, and I can't see any hand up. I'm going to wait another few seconds. All right. Yeah, there we go. Right. Yeah, okay. They're starting to come thick and fast. So Bemi says that QI to me is a way of improving our services. Okay, that's a good one. Enhancing the quality of care given to service users. Thank you, Ada Ora. AJ Kano quality improvement to me means steps taken to add more value to whatever services are being offered, improving services in patient care. Thank you very much for all those thoughts. Improving service delivery. All those thoughts are valid, and improving quality of services, maintaining and sustaining it should a key performance indicator. Thank you. That's really helpful, and I'm sure there are more thoughts coming through. Now, for the sake of time, I'm going to go to my next slide, and this gives you a bit of an insight into the three, if you like, three dimensions in which I have seen quality improvement or QI being used. At least these are the three dimensions in which I've tried to make sense of colleagues when they say QI. These are the three things I've figured out they mean. And by all means, if you have a different framework or a different model, or there are other things I haven't necessarily picked up on, by all means, please put them in the chat as we go along. So different usages is what we're talking about here. So first, QI as a culture. Now, this is the more generic term. So when people say QI, often what they're really referring to is QI as a culture. They're referring to quality improvement as a culture. It's often generic. It's often used by high-level thinkers. What I mean by that are usually the senior leaders in our organization. If you hear a chief exec speaking about QI, if you hear a member of the board using QI, if you hear a non-executive director using QI, most times they're referring to the cultural usage of QI. They're not referring to the other things. They're generally referring to the cultural usage of QI. And I just want to read this out to you. So the Oxford Language Dictionary defines quality as the standard of something as measured against other things of a similar kind. So the dictionary defines quality as the standard of something as measured against other things of a similar kind. It also defines quality as the degree of excellence of something. So what that tells me is often when colleagues use QI in the cultural context, what they're really saying is, this is about excellence. This is about, it's about simply aspiring to improve the standard in healthcare. It's about an aspiration for excellence. So they're using it in a very general term. It's an aspiration for excellence. It's an aspiration for a higher degree of excellence in the services that we offer. And notice that a number of practically every one of those different things we put in the chat box really links up to that sort of cultural usage. So it's a very common one. It's very accessible, and it's often used. So in colloquial speak, often when we speak on the floor of the trust or the floor of the organization, we're often referring to that cultural usage. We're referring to a degree of excellence, an aspiration for excellence, right? That's one. The second one, however, is the scope. And what I mean by scope is this. You know, in 2008, Lord Ajayi, many of us might recognize that name. Lord Ajayi did a piece of work where he looked at quality improvement, and he looked at quality in the context of the NHS. And of course, there are a number of other definitions of quality that have been provided by institutions, including the WHO, right? And the one definition that Lord Ajayi did in 2008 is he did a number of interviews across the NHS. He looked at the different things that we did in terms of quality. He spoke to patients, he spoke to professional groups, et cetera, et cetera. And he came up, and his concept of quality came down to three things. And he defined quality in three dimensions across the NHS in order of priority. The first is patient safety. And according to Lord Ajayi's conception, at the very least, when patients knock on our door, when they turn up at our doorstep, the first and most basic thing we can do in terms of quality is at least not do any extra additional harm to them. They already have a problem, a clinical problem in many cases, and they've come to us to seek help. The very least we can do in terms of quality is at least not make their problems worse. Now, forgive me, I think I speak in English, but sometimes I think in Yoruba, so forgive me, right? I'm just going to put that out there, right? Now, there's a Yoruba adage, and for those, well, we're Nigerian physiotherapists, so everybody should know what Yoruba is. And if you don't, honestly, ask me offline and I'll tell you. But there's a Yoruba adage that says this, that if you go to an oracle, right, to seek a problem, right, your position is, if the oracle can't help me, at least the oracle should not hurt me, right? Hopefully that makes some sense. In other words, if we can't help the patients, at the very least, let's not hurt them. And that's the dimension of patient safety. So first, patient safety is the first dimension of quality. The second dimension of quality is clinical effectiveness. They've come to us for a whole host of reasons. It could be neurological, it could be respiratory, it could be psychological, even in some cases, or it could be musculoskeletal, and so on and so forth. The list goes on. But we set ourselves some clinical targets that we want to achieve with them, and it's important that we deliver on that clinical effectiveness. So that's the second dimension of safety. And remember, we're looking at scope here. And the third dimension of safety is patient experience, right? Throughout the experience, it's not enough for us to keep them safe. It's not enough for us to deliver the effectiveness, clinical effectiveness, but we ought to aspire for them to have a good positive experience. So too many times this happens, and I've heard this said on more than one occasion, where somebody has an encounter with one of our services, whatever that service happens to be, and we keep them safe, we deliver on our promises for clinical effectiveness, but somehow they have an encounter either with one of our receptionists, or they have an encounter with one of us, and we happen to have been, for whatever reason, had a very unusual off day, and we were slightly short on our fuse on the day, and we weren't as polite as we possibly could have been. Guess what? The patient completely forgets that we didn't hurt them, at least in terms of safety. They completely forget that we delivered on our clinical effectiveness and delivered what the thing said, right? And what they remember is that somebody was rude to them, or somebody was short-fused with them, or somebody didn't treat them right? I'm saying that to say patient experience is important. In order of priority, when we define quality, we're talking about patient safety first, clinical effectiveness next, and patient experience next. However, all that said, probably the one thing that's likely to generate, what's the word I'm looking for, complaints more than anything else, is patient experience. And so it's just a balance that we often have to dance with. So all that said, that's Lord Darcy's conception, and that format, that model, that framework is often used still in the NHS. 2000, and it's about how many years old now? Going on to, it's about 17 years ago, Lord Darcy came up with that conception. Now, another interesting aspect of this, of course, is that you'd have also seen the latest report by Lord Darcy about the NHS and the priority areas we should focus on. For some reason, I think Lord Darcy is a master at using the three-pointer approach to getting his message across. So in 2008, it was patient safety, clinical effectiveness, and patient experience. For all it's worth, in 2024, his latest report, which I jokingly call Darcy 2.0, not out of disrespect, but out of just how much longevity the prof has had in healthcare and in the quality space. It's three big things now, and these have direct relevance to quality. It's three big things are going from hospital to community, going from treatment to prevention, and going from analog to digital. Again, 3 points which all have relevance to our practices, and which in some sense, given the events that have happened in the last 2 days, the last 3 days, and the last week, probably the most eventful time in the healthcare space over the last decade or two. Given those kind of events, it's important to get a sense for where the government's mind is in terms of the big ticket items for healthcare, which of course then determine the priorities for quality improvement and patient safety, et cetera, et cetera. So I just thought I'll throw that in. So now the third dimension of quality is as a method. And the use of quality QI as a method tends to be more familiar and more rampant, I should say, on the front line. So if you're talking to your band 5s or your band 6s or your band 7s, etc., if they say quality improvement, 9 out of 10 times they are referring to a method. They're referring to the IHI method for model for improvement, for example. And for those who may not be familiar with that term, IHI is Institute for Healthcare Improvement, based in Boston in America. And they have done some pioneering work globally in quality improvement in healthcare. So often, if you hear a frontline person use the word quality improvement or the term quality improvement, they're often referring to a method. Either they're referring to the IHI method for a model for improvement, or they're referring to Lean, or they're referring to Six Sigma, and there are other methods out there, but often it's method. And I know about the other two, the Lean, I know about Six Sigma, and I've done some training on all three, but I'm more conversant and more comfortable with the IHI model. And so I will be looking at the IHI model for the rest of the afternoon. So let's take it one step further.
Sorry, I think somebody's hand is up. I don't know if he wants to ask a question. Emmanuel Ayeleke.
Thank you for prompting me, Victor. I didn't spot that.
All right. Emmanuel, do you have a question before we go ahead, before he goes to his next slide? All right, we can go ahead, please.
Okay. So now, you can boil the IHI method down to five strategies, if you like. And I see 2 comments have just come in. So let me just pause and let you read those out to me, Victor, and then I'll go further.
There are no comments now. I think, yeah, there are no comments. It's just Emmanuel that said no, he doesn't have a question. Yeah.
Right, fantastic. Thank you. That's helpful. Right. So the first strategy in the IHI model, essentially, is determine your aim. And I'll unpack this a bit more. Determine your aim. And that may seem a redundant strategy to include, but my experience in working in patient safety, quality improvement, innovation, transformation, system leadership over the last several years has taught me that one of the most important things that we always have to do is to determine aim. In other words, what problem are we really trying to solve? And this is worth its weight in gold. And I'm sure there are colleagues on the call who can relate to this, in the sense that the problem does not always present itself in the most solvable form at the first opportunity. Let me say that differently. Often, what we see as the problem might only be symptoms of a bigger problem. And therefore, it's very important for us to take the time it takes to define what our aim is and what we're trying to achieve. Let me say it differently. Too many times, I have seen situations both in patient safety and in quality improvement, and I'd say even in other spheres, where what you have is simply a solution looking around for a problem. What you have is simply an innovation looking around for a house to manifest itself, right? And this is why it's very important for us to start by being very clear about what the aim is. There's the a statement that's been credited to, I believe it's to Albert Einstein, that if I had 100 minutes to solve a problem, I'll spend the first 95 minutes defining it and the last 5 minutes solving it. And I think that's really, really wise, because my experience has been that being clear in our minds as to what we're trying to achieve is extremely important. So determine your aim and be clear in your mind. Where are we going? What do we need to achieve? And I'll come back to that as to what a good aim is and how you might set one up. But let me just throw this out there to start. There are 3 dimensions to that aim. First is, what are we trying to achieve in the first place? Right? By how much are we trying to achieve this? By how much are we trying to make the change? How much change are we looking for? And the third is by when. So it needs to have a very much specificity in terms of what are we trying to achieve, by how much, and by when. And I'll unpack that in a bit more detail later. So first, determine your aim. The second is develop your theory of change, right? And for for a number of years, I used to hear people use the term loosely: theory of change, theory of change, theory of change. And I used to scratch my head and say, what do they mean by theory of change? What is theory of change? What do you mean theory of change? And I found a very easy way of explaining to myself what I think theory of change means. I think theory of change simply means, what is our hypothesis about how we're going to move from where we are now to where we're aiming to get to? In other words, what is our way of explaining the steps between where we are now and where we are going to ourselves? Another way of saying that is, what is my hypothesis as to how events will pan out from where I am now to achieve what I'm looking to achieve in quality improvement? And often that's presented in the form of a driver diagram. And colleagues in the room might be familiar with the concept of driver diagram and how that plays out in reality. And I've got an example which I'll be sharing later of a driver diagram, but a driver diagram often serves that purpose. The other thing that you then have to think about, now the reason why the theory of change is important is this: starting out on a QI project, or starting out on a quality improvement project, or any project for that matter, without being clear in your mind as to what your theory of change is a bit like starting out from London, heading to Manchester without a roadmap, without satellite navigation, and without previous knowledge of the route, but just going out on a wing and a prayer and just heading north and expecting that somehow you get there. You might get there, but you might not get there as quickly as you might want to. So, right, okay. I think somebody is trying to write, or can you see the thing on the screen, the blue?
Yeah, that may be your scroll.
Oh, right, okay,
Yeah.
right, no problem. So, yeah, so that's developing. That's why it's important to develop the theory of change. Now, I heard a story, just talking about the theory of change. I read a story in one of the NHS large-scale change documents and resources I have been privileged to use over the years. And that story has stuck with me. So in the early 1900s, I think it was about 1917, during one of the world wars, it might have been the first or second world war, I forget which one. But anyway, there was a detachment of Hungarian soldiers who were going on a reconnaissance mission, right? And they were going on a reconnaissance mission in the Pyrenees, right? And so they set out on this mission, but unexpectedly in the Pyrenees, it started to snow. And of course, when it starts to snow, suddenly very familiar landmarks suddenly disappear. Everything gets white, and you can easily get lost in the middle of the mountains. And so the detachment of soldiers start to panic because they're on this reconnaissance mission and they're lost in the middle of a mountain range in the Pyrenees that is completely unfamiliar. And in the middle of the commotion, soldiers are trained to be temperate, they're trained to be measured, they're trained to be rational at all times, even when their life is in danger. Because if you can't do that, you ought not to be a soldier, right? So in the midst of that commotion, one of them pulls out a map, right? They're in the Pyrenees, right? He pulls out a map. Everybody is excited. Thankfully, thank God, at last, they can navigate their way out of this mountain range in the Pyrenees and get to their destination, right? And so, lo and behold, they follow the map, right? Letter, line by line, follow the map, and they emerge at their destination and complete their reconnaissance mission in the Pyrenees, right? After the exercise, as soldiers do, and as some of us colleagues do, they did a debrief and found out why did we not even predict that it was going to snow? How did we make our way out of what could have been a very terrible situation, being discovered by the enemy or ending up dying of hypothermia, et cetera. And so they decided to look, of course, the turning point was when they found the map. They decided to look at the map, and guess what? The map they had, which navigated them out of the Pyrenees, on the understanding that it was the map of the Pyrenees, was actually a map of the Alps, right? So these guys managed to use a map of the Alps to navigate out of the Pyrenees, believing that it was the Pyrenees they were navigating in, right? Believing that it was a map of the Pyrenees. What does that tell us about driver diagrams and theory of change? It tells us that the important thing really is not to get your theory of change 100% right. Just have one, because if you have one, you have landmarks, right? You have something to guide you. Having a terrible theory of change can be modified over time, but not having one just puts you in no man's land and makes it really difficult to navigate. So have a theory of change. And the reason I say that is to say it's not always, the skill is not to get it 100% right, but have one and then iterate it as you go along. Finally, so the third strategy, have a measurement strategy. I could, this strategy, having a measurement strategy is so important. Is so important. In other words, how are we going to know that the change that has happened is even meaningful and is taking us in the right direction, right? And the measurement strategy is about three things. First, process. What are the things we need to put in place? Do we need to buy new equipment? Do we need to train staff? What are the things we need to put in place to take us in the right direction? So it's a process. It hasn't delivered the result yet. It's a bit like exercise. Exercise is not a means to an end. The real end is better fitness. The real end is better range of motion, et cetera. But if you don't exercise, you don't get all those benefits. And so the process is an important thing. What are the processes we need to put in place to take us towards the outcome? And then also, what are the outcomes we are looking to achieve? And I'll say a bit more about that later. And finally, the balance measures. Balance measures talk to the unintended consequences that might result from exercising the process measures. And in many cases, you might achieve your process measures, you might achieve your outcome measures, but you might blow the budget by 50%. That's not, you don't really want to be in that space. So you need to think about what the balance measures are and to track those also. So outline number 4, what's the implementation strategy? When I mention the term QI or quality improvement, probably everybody in the room would automatically think of two things, almost always, driver diagrams and PDSA. And again, in my early days in this space, probably 20, 15 years ago, I used to always think, PDSA, PDSA, what does that mean? PDSA. PDSA is plan, do, study, act. And every clinician in the room is already doing that. We plan a treatment session, or we plan a treatment program. We have a treatment plan. We deliver the plan, or at least start out in delivering the plan. We then monitor it, we track it, we study it, and then we adapt it is the word I'm looking for. And that's a PDSA cycle, essentially. We plan, we execute, we study, and then we adapt, as the case may be. And strictly speaking, PDSA is plan, do, study, act. And finally, we got the final point, which is the spread and adoption strategy. The Lord Darzi, I think this is credited to Lord Darzi, but there's this saying in healthcare, in quality improvement circles, that says that we're aiming to make sure that what we know is what we do. In other words, that there's an alignment between what we do and what we know. In the sense of a number of researchers in the room and my research colleagues, Francis, Victor, would be able to relate to this. There's a huge gulf, a huge gulf between what we already know works, what research already tells us, what innovation already tells us, the evidence that we have, and what we do. If today, never mind all the problems that have been heralded in the media over the last 1 week, if today we got to a point where everything we know, well, I've said everything, 10% of what we know in research and in innovation, if we're able to scale that across the front line, right, the NHS will suddenly become, it will improve by leaps and bounds, right? So there are times when I have seen this happen or had this happen in times where there are two trusts side by side, and one of them has cutting edge services, evidence-based services that are delivering outcome again and again and again. And you come to another one and lo and behold, for some reason, they're not nearly on that level. And so very good practice and not so good practice, mediocre practice might be sitting side by side because we're not doing well at spreading and scaling the strategies and innovations and quality improvement that we already know works. So now, this is a summary of the IHI model. And I'll hit some headlines on the slides and move us on. So remember we said earlier, what's the aim? What are we trying to accomplish? What changes do we need to make that will result in the improvement we desire? And finally, how are we going to measure, or how are we going to know that a change is actually an improvement? A change is not always an improvement. How do we know that a change that we're the change we're making is actually an improvement? Now, this is very interesting because I'm getting additional help from whoever in redesigning my slides and making them really more colorful. I like the blue and the green, so it's exciting. But anyway, for all it's worth, what is quality improvement? It's a systematic use of methods and tools to try to continuously improve quality of care and outcomes for patients. Now, some of these slides are slides that I have accumulated from programs I've been involved in over the years, and some donated by colleagues who worked more closely with some of those programs. So there are various methodologies and tools, but common to all of these are using data to understand variation and impact, involving staff closest to the issues that are being investigated, and certainly testing small changes in trials as a way to learn and improve. So one of the biggest things about the IHI method is that you don't launch in, and it doesn't matter how effective a solution has been in another setting, you don't launch in and assume that it will work in this new setting. You start out with small tests of change, and then you adapt and contextualize the new methods or the new ideas until you get them just right for the new setting. So we get an aim, we ask ourselves, what can we change to make the desired improvement? And then we ask ourselves, how are we going to measure? How are we going to know that the improvement, the change is actually an improvement? Right. So, and that takes us to PDSA cycles. I alluded to this earlier. PDSA cycle is when we then decide, okay, this is what we would like to change. These are the actions we would like to, the change ideas we would need to make. So we plan, we implement the change ideas by acting, we study the effect in the first cycle, and then we make alterations and we do another PDSA cycle. And we go through cycle after cycle after cycle until we achieve the aims that we set ourselves. Now, I'm going to stop sharing just for a minute, and then I'm going to navigate to another slide. Just whilst I'm doing that, if there are any immediate questions or comments or reflections, then by all means, let's take that. But I wanted to just come up with this example. Let's see. Okay. Some reason. Can you hear me still?
Yeah, we can hear you.
For some reason, I've lost control of my mouse, but so bear with me 1 minute. I'm not sure what has happened, but there's been a glitch, but I'll sort it out in a minute. Please bear with me 1 minute and I will be back with you. I'm just literally resetting my mouse. Not sure what happened, but my mouse just froze. Right, I think we're back on, so let's see. Yeah, thank you. Sorry about that. I'm not quite sure what happened, but my mic and my mouse just literally froze. So let's go to this example. I've got a few examples, but I wanted to just highlight one particular one just to start to bring a bit of flesh onto presentation, if you like. So let's look at this one. And it's a QI example in neurology. And I will share my screen again, and we can go from there. Right, so right, can you see my screen?
Yes, yes, we can see the screen.
Right, okay.
Yeah.
So right, so I'm just going to give you a moment to have a look at this. Just have a look at this exercise for a minute. For all it's worth, I thought to myself, let's see how we might bring artificial intelligence into this. So I wrote a script for ChatGPT and asked ChatGPT to spew out an exercise in quality improvement, and this is what I got. So I'm going to ask you to do two things. First is to sense check it from a practical clinical perspective. Does this even resonate with you from the front line? And secondly, we can then start to unpack this and really use this, if you like, to engage in a conversation. I'll give you a minute to have a look at that, and then we can unpack it. Right. So let's take some thoughts. First, does this even ChatGPT can have different degrees of accuracy, shall we say. But let's take some thoughts from the clinicians in the room, practitioners in the room. How much does this resonate or not resonate with you in terms of reality? There are 63 colleagues on the call, so I'm going to take a punt at calling a name out if I don't get any responses. Right. So let me see. Azizat? Right. Okay. I'll just walk my way through until I find somebody who can. All right. Okay.
I
Thank
think
you. Somebody.
Bemi said it resonates with her. So Bemi, do you want to say something, please? Bemi Ojabode.
Thank you, Gbemi, for rescuing us from the silence abyss.
Good evening, everyone.
Good
Thank you.
evening.
Thank you, sir. Yeah, I think it actually resonates with me. I'm not sure of what to say.
Okay.
All right. I think I will help you, baby.
Okay.
I'm a neurophysio, and I say it resonates with me very well in the sense that this is, like you said, it's going to be high tech. If we look at it, QI has given us a high tech approach, introduced digital rehabilitation, which of course is what you will do high tech, looking at virtual reality, looking at 3D, looking at 3I, looking at all those big things in terms of rehabilitation to encourage patients to participate. However, in our everyday practice, that becomes a little bit unrealistic because we may not have all those facilities to get the patient engaging, apart from encouraging the patient to engage, encouraging relatives and family members to engage them in activities that will help them improve. But technically, if you incorporate things like VR, virtual reality, 3I, and a handful of other technology, the patient will participate and at the same time perform better than expected, and equally that would encourage uptake or encourage adherence to exercise.
Thank you. Thank you. Thank you, Gbemi, and thank you, Victor, for bringing your perspectives on this. I saw a hand go up and then go back down. Was that person wanting to chip into the conversation?
I don't know the person who did, but I just wanted to share my thoughts. I don't know if that makes sense. I'm not neurophysio by background anyway. Sorry,
Go
my name
ahead,
is
please.
Informa. But when you were saying about AI, the only thing that came to my mind was while I was still back in Nigeria, we did talk about telephysio, especially during
Mhm.
COVID-19. So when you were talking about AI, the only part I could think about was telerehabilitation. Due to COVID-19 and because of how contagious it was, we couldn't really go out. You could understand that somehow in Nigeria, physio were more or less sidelined somehow because even when they were talking about in Nigeria about frontliners, I guess because they didn't really see us, we're not necessarily in the primary healthcare of things back home in Nigeria. But then we're saying another way we could have made ourselves or that can help us to still be there and still deliver services in a situation like COVID-19 was telerehabilitation. So it became a real big thing down there when we could actually give patients. One of the things I think we were doing was to be able to give patients maybe some exercises via telephone, Zoom, and giving them maybe sharing videos of the similar exercises we wanted them to do. Before now, it wasn't before COVID, I don't think it was that popular. But with COVID, that was one of the things that became popular. And I didn't think it was possible without AI. So when you were talking about this AI approach, I think what came to my head was telerehabilitation and how
Right.
popular it came about because of COVID-19.
Right. Thank you very much, Ifeoma. That's really, really helpful, and that brings a really cutting edge frontline dimension. And I think there was another, well, okay, for the sake of time, we'll move on. And so in the context of setting an aim for this exercise or for this quality improvement project or example, for example, we may say the outcome measure we're desiring, which is the aim, this is the big ambition, is to increase reported exercise adherence by 50%, from 50% to 80% within 4 months. Notice that there are 3 dimensions in that outcome measure, which we mentioned earlier. The first is we're clear about what we're trying to do, right? Exercise adherence is what we're trying to improve, right? So that's very clear in our minds. We're trying to improve exercise adherence. The second thing is by how much. Essentially, we're saying the current level of adherence is 50%, and we're looking to improve to 80%. So we're looking to improve by 30%. And that ambition is not somehow in the yonder by and by. That ambition is to be achieved within 4 months. And that then leads us to another important principle in these strategies, which is the principle of baselining. One of the cardinal mistakes that anyone can make in quality improvement is to launch in, to start to implement your change ideas before you've even determined your baseline. In other words, you haven't even set what ground zero is, and you're already running. The problem with that, of course, is once you start running, once you start initiating change ideas, you can't go back to ground zero again. In other words, you've missed your baseline. You only ever get one opportunity to define your baseline, i.e., what is our starting point? At this point in time that we're going to start to implement measures, what is the current exercise adherence? If we don't set that and we start introducing new measures, whether that's digital, whether that's tele, physio, whatever it might be, we've already lost the opportunity. And this is a cardinal issue. We've got to set our baseline first. What's the starting point? Then we can see if we're making improvement or not making improvement. Here we're looking at one of those principles, the implementation principle. This is principle 4, where it says the PDSA example. Testing video-based exercise guides with a small patient cohort and then rolling it out to stroke rehab patients. And rolling out really refers to the 5th strategy, which is the adoption and implementation strategy. So we're thinking in terms of how are we going to roll this out? So are we going to start from 1 service and escalate to 3 services? Are we going to aim to escalate from the 3 services to the rest of the trust? Or are we going to aim to escalate from the 3 services to the entire hospital, from 1 hospital to 2 hospitals, from 2 hospitals to 4, et cetera, et cetera? And if you are able to do this right, I have had experiences where you are not only able to scale within a trust, but also to a region, an ICB, and an ICB nationally, et cetera, et cetera. So, and that basically works. So that's one example. Another example is one in respiratory physiotherapy. And the respiratory physiotherapy example is where essentially we're looking to enhance airway clearance in patients with chronic respiratory conditions, whether that's COPD or any other condition, and cystic fibrosis or any other condition we might care to name. The problem here being suboptimal use of airway clearance techniques leading to increased hospital admissions for exacerbations. A QI approach might be to introduce personalized educational sessions and self-management plans for patients. An outcome measure might be reduction in the respiratory-related admissions by 20% within a year. So again, we are clear about what we're trying to achieve. We're looking to reduce respiratory-related admissions. We're looking to reduce that by 20%, and we're looking to do that in 1 year. Now, somebody might say, well, how is that going to work in practice? How do I know to aim for 20%? How do I know to focus on respiratory related admissions? How do I know that 1 year is a realistic target? Well, all of those questions are valid questions, and the answers to them lie in local knowledge. In all probability, if I were to ask you these questions in the context of your service, 9 out of 10 times, you will give me the answers to those questions in your sleep. And if not, you might be able to quickly go into your records and say, based on the pattern we've observed over the last 1 year, I can tell you that these ambitions are realistic or they're not realistic. So that's a subject of local intelligence, and it's always to do with how much local data we have and how we interrogate the data and ensure that we involve frontline colleagues in this decision-making processes. So let me go back to, sorry, I'm going to have to flip. Actually, there might be another way of doing this. So I'm going to go back to an earlier slide and essentially try and wrap up on this in terms of, what's the word? In terms of wrapping up and then leaving this open to conversation. So bear with me 1 minute and I'll go to an earlier slide and we can then finish or at least go to, right. So remember our strategies, 5 of them: determine your aim, develop your theory of change in form of a driver diagram. That developing a driver diagram is an entire, if you like, webinar on its own. Outlining measurement strategies, process, outcome, and balance measures. Outline the implementation strategy, PDSA, and outline your spread and adoption strategy. Let me leave it there for now. I'm conscious that we've gone all the way to 6:05 and I've spoken for nearly an hour. So let me stop and just take questions, comments, reflections. As I said, this was intended as a high-level picture of QI and patient safety, making the link between those two concepts and just throwing some strategies out there, all of which can be unpacked. Right, so back to you, Victor.
First of all, I will say, before we start taking the questions, I know some people want to disappear. I want to say thank you very much, Kenny. That's a high-powered lecture on quality improvement and patient care, where in my university, we do quality improvement as a dissertation for the students. And what you've said actually resonates and it's brilliant. I'll say thank you very much. So we'll have a lot of questions. I can see Professor Francis. I can see Adekunle has their hands up. So let's start with Prof. Then we'll go to Adekunle, please. Then we can ask any other person, please, listen to the questions and ask your questions. I think we benefit a lot equally, apart from the lecture, we benefit from the questions. So Prof, please go ahead.
Prof, thank you, Victor. Prof, it would be good to see your face if you are able to, in a place where you can show your face. Presenter prerogative, if it's possible.
Sorry, I'm not sure.
Don't worry, that's fine.
I was watching football with my 28-year-old son, but I had to sneak out somewhere to speak.
That's good.
Bonding time. Thank you. Thank you very much, Kenny, for your wonderful presentation. I've really enjoyed it. I just have 1 or 2 comments, but before I go to my comments, just to also appreciate Dr. Uti. I think I could also see Tunde Ogundumade on the call. So
wow.
Back
reunion.
Then, reunion. That was just what I was about to say. Nearly 40 years ago, I'm not sure we've had these where 4 of us will be together under one roof, or in a virtual environment like this. I think this is really fascinating. Yeah, going back to my comment, I think just really around the definition of quality in terms of the how you described it from Oxford Dictionary, which is excellence, and the other one was around the Lord Darcy's report, which is patient safety, clinical effectiveness, and patient experience. Okay, I'm just trying to lay a bit of background. So we know very well as a health economist, we know that budget will continue to be constrained, whether we like it or not. So people, colleagues in clinical practice are being asked to do more with limited resources. So, and there's also the concept of efficiency, or in particular efficiency savings. So I was just wondering what your thoughts were around, or in terms of the importance or significance of cost effectiveness when we talk about quality improvement.
Yes, that's a great question. The significance of cost effectiveness in quality improvement, and trust and health economists to ask that question. Yes, I think it's incredibly important, and I think where things work well, in reality, when we do quality improvement, in reality, I think we should be coming up with options that help us to improve productivity to the point where really cost effectiveness then comes out as a byproduct of that. So going, for example, to Lord Darcy's latest report around going from analog to digital, from hospital to community, and from treatment to prevention. I'm sure that from your health economics perspective, if we were really to be able to use quality improvement to achieve those three ambitions, even though it would involve an initial outlay and an initial investment of time, initial investment of money, initial investment of resources upfront, further down the line, further downstream, we would achieve cost effectiveness. Further downstream, we would achieve productivity, and the investment would have been worth it. I think from my experience, and this last thing I'll say on this point, from my experience, the challenge is two things. One is there's a reluctance to make the initial investment to make the changes that you require to free up productivity and to make the gains you require in the first place. And that's often in terms of headspace and also in terms of funding. I have jokingly said this, that headspace in the mind of an NHS clinician is probably the most expensive real estate that exists anywhere in the world. Headspace in the mind of a clinician in the NHS is more expensive than real estate anywhere in the world. I say that to say, if we don't free up the time to really focus and get the headspace to do quality improvement in the first place, there's less chance that we will end up achieving the cost effectiveness that we might aim for. I hope that addresses the question.
Yeah, thank you very much. I've been able to secure a safe space where you could see my face.
It's good to see your face.
Thank you. So I absolutely agree with you, because most times when we talk about cost effectiveness, a lot of people think that, or health economics in general, a lot of people think that we are just cutting costs at the outset. Not necessarily. We're looking at the effectiveness versus the cost, and it may not necessarily be immediate effect, but it might be a long-term effect, as you have described it. So there might be an initial cost, high cost to be incurred for us to get the maximum benefit. Thank you very much. Nice to see you again.
Before you continue, Ademola will ask the next question. But before then, I just want to inform you, Kenny, we have Ajayi Adiogo on the call.
Wow.
Tokwe and the husband on the call. We've got Ajayi, elder statesman on the call.
Really?
We've
Wow.
got Francis, we've got a handful of your classmates here. It's interesting.
That's
So
interesting.
you're seeing them after 35 years.
Well,
Yes.
you can blame Uti for that.
I know. I know he's a very powerful man.
It's
It's interesting.
it's always been. It's always been. Anyway,
I think before Tunde, I mean before Adekule will say something, I would like to say, Kenny, you've presented a quarter of your presentation. I think I'll be glad if we can call you back again to finish it up, because there's so much I can see on your slides that are still of importance that we've not really hit because of the time factor. So we'll be glad if you join us again to do that again. But before then, let's allow Adekule. Dr. Adekule, please, your question.
Thank you very much. Mr. Kenny, thank you very much for the presentation. Much appreciated. And
Thank you.
if I may just ask, you've touched around balance strategy, and it resonates highly, especially in the current climate of cost cutting. This week or in the last few days, we've been made aware we may no longer have, or we will no longer have NHS England, the way things are going. Hugely, we contest, or a bit of conflict, if I can put it that way, between evidence-based or best practice and affordable practice. Many times I've had that discussion around program fidelity and adaptation. What you can obtain in the laboratory, a well-controlled research setting where you look at treatment and patient and effectiveness, and what you can actually achieve when you come to the real life in the clinics, in the services where you've got operational challenges. Where do we draw the line between gold practice or gold standard practice, silver standard, bronze standard? There's been different descriptions just to make sure people accommodate something, but slightly we are sliding down sometimes far from what real evidence is saying. What are your takes on this?
Thank you. That's an incredibly pragmatic and true to life question. And my take is, I guess, 2 points really briefly. One is, I believe there's enough ingenuity always on the front line to come up with the improvements that we need, even if it means we just make incremental improvements, little improvements, right? And there is no doubting the fact that the system is under the most amount of pressure it has ever been. So we're not denying that by any stretch of the imagination. However, you also know, I'm saying something that you already know, that the system also has some of the most incredibly ingenious people that exist anywhere. Certainly, I can say that for the UK, and I can say that for Nigeria. I haven't trained in Nigeria myself. And so I'm saying that to say, even though there is pressure on the system, there is still enough ingenuity to at least move us forward, even if it's in small inches, maybe not in massive leaps, but in small inches. And often that can incrementally lead to significant change over time. But however, I come back to a point that Professor Fastoye made earlier, in the sense of there comes a time when we've got to make some initial investment. Nothing goes for nothing. If we don't make that initial investment, we're never going to get to a point where the system is as improved as we want it to be. And I'll make one final point. Your point around there's evidence, and we all know what the evidence is often, but making it work in a certain, in a clinical setting on the front line might be a different story. But I really believe that ingenuity of the people on the front line can overcome many of those obstacles. Let me tell a quick story. There was a quality improvement project that was set for, or a design project that was set by a Harvard professor for their engineering engineering team or engineering MSc program in design. And the program was up in the mountains in Pakistan, that I believe it was in the Himalayas. There was children, newborn neonates were dying of hypothermia. And the challenge was come up with a design that will mean that we can have incubators that will transport these children from the altitude of the high mountains to the nearest hospital, which is 2 hours away. Come up with a technology that will deliver that, right? And of course, it has to be a technology that is low in energy consumption, technology that is easy to move because of the distance that has to be traveled in very difficult terrain. Of course, these engineering students, some of them have degrees from the best engineering schools in the world. So they start to deploy their engineering skills. They're trying to develop an incubator that will be lightweight, low fiber, et cetera, low energy consumption, et cetera. Well, guess what? They didn't need that sort of incubator. All they needed was a good old, well-designed blanket that you can wrap those children in neatly and carry them over a 2-hour journey to the places where they need to be to get into hospital. And that sort of ingenuity makes the point about sometimes it's the creativity of the people on the front line that really delivers the kind of results, low-tech results that we sometimes need and low-cost results. But thank you for the question.
Thank you, sir.
Thank you very much. Please, do we have other questions, please? All right, before we go ahead to give vote of thanks to our erudite colleague, Kenny Ajayi, I will seize this opportunity to invite those of you that live in the UK to join us as the physiotherapists here in the UK. We have an association and we are trying to build knowledge. We are trying to build education. We are trying to build gathering together so that we can learn from each other as well as help each other. Because we are far away from Nigeria and the NHS in this country is a difficult terrain. Some people might find it challenging, especially those of you that have come newly. Working in the environment can be challenging also. It's an opportunity to join the Nigerian physiotherapists in the UK as an association, and we'll be able to shed more light and show you the way because we have colleagues that are really experienced. I would call on our able PRO, Publicity Secretary, to kindly give vote of thanks to our presenter. But before then also, we are going to be having another presentation on the 22nd of June, 2025, and that will be by Professor Yetunde Dairo. She has developed a tool which has won her accolades with the CSP and the HCPC, Chartered Society of Physiotherapy and the Health and Care Professions Council. She designed a tool called the Single Line Measure for Disability, which of course assesses intelligence as well as other things with people that are disabled. She's already taken that far away and we'll be glad if she comes back home here to give us a talk about this tool she has developed. So please look out for our invite again. That will be on the 22nd of June, 2025. And for Kenny, we are definitely going to invite Kenny again to come and finish up what he has started. So I'll call on the PRO. Are you close by, please? Kindly give us a vote of thanks to our erudite scholar.
Good evening, everybody. Don't know if you can hear me. All right. Thank you very much, Mr. Ajayi. Actually, when we started this, it just resonate the experience, the little challenge I faced when I wanted to do a QI project in my trust. I'm like, oh, how I wished I've known all this before I did the QI project. It would have been just something like, oh, are you a consultant in this before? But good, at least we're still on other QI projects. QI project never finish in a trust, especially when you want to be a part of it, when you want to be a part of change, not just to be a figure in that association. You always try to bring impact. You always try to bring improvement everywhere you are. Thank you very much for this. And I so much believe that everybody that attended this meeting have learned and gained one or two things from this presentation. It's quite unfortunate that we could not finish everything, because I'm very sure we still have a lot to learn from this powerful packed presentation. Thank you very much, and I hope when we beckon on you again, you will actually honor us with your presence. I know you're a very busy man. Like, I've chatted you on LinkedIn and like, oh, this man is very busy from year to year. Thank you very much. It's a privilege to have you on this platform. Thank you very, very, very much for honoring our invitation. Thank you very much, and God bless you, sir.
Thank you for having me. It's a privilege and a honor to be invited, and I can't possibly say no to Dr. Victor. So I'll be back as soon as we're able to align dates. And I thank you for the good work you are doing in the community. It's really remarkable, and I'm just chuffed. Thank you.
You're welcome. So
right,
hopefully you'll be able to give us the I don't know, maybe it will be part of the presentation, at least where we stopped, so that we can send it to people that are interested, and they'll be able to go all over it again, because I know a lot of people, they are in the middle of starting a QI project. A lot of people are like, how do you do yours? How do we start? How do you do this? And this will actually set them right. Please, sir.
Yes, I will send the slides to Victor, and then we can go from there.
Thank you very much, sir.
Okay.
Thank you very much. I will be posting the presentation today, which has been recorded. I'll post it to the forum. All the forum have invited you people. So you will definitely get a link. It will be open, and you can be able to view and listen to this particular seminar. Thank you all. And Kenny, thank you once more. It's an opportunity to have met you again, although online, after several years, and a few of my colleagues also that I've seen online. Thank you, everybody. And please look out for our next invitation for our series of seminars. Thank you.
Okay.
Please, all therapists kindly contact the PRO. The PRO will be able to put your name on the line, and we can all talk. Tunde, we say hello to you also. All right. Thank you, everybody. Bye for now.
Okay. Bye-bye.
Bye.
Victor, you didn't share the tips, so you didn't share it.
The tips of being look at Francis, is younger than me now.
Which
People should share the tips, so let's get it now.
I think it's just good life.
Yes.
Just stay calm and just work as much as you can without stress. That's the tip.
That's what I'm saying. How do you work without stress? That's the tip there. Do you work without stress in NHS?
All the seniors in the UK should share the tips.
Oh, exactly. Okay, you see, I'm not the only one needing that tips, because I want to understand how you work without stress in NHS.
I'm telling you.
Maybe you need to come to academia.
You
should. We want clinicals.
Have you heard about the Dr. Victor Chill Pill?
Okay, I do know about it. I've not heard about it actually. Dr. Victor, that means you will not rest.
Thank you.
Yeah.
No problem. We'll send it.
Hi, Mr. Kenny. I just wanted to say something. My name is Bemi. So
yes.
Thank you so much for that presentation. It was really brilliant one. I didn't know so much about QI, and now I know there are lots of things in QI. So when I was checking your LinkedIn, I saw that you actually NHS leadership academy alumni. So